Hey everyone, it's Dr. Wood, and today we're going to continue on talking about our urology topics, including benign prostatic hyperplasia coming up first. Basically, this is a pretty common problem that will be found in most men, especially as they get older. In many patients, it tend to be benign. But we'll talk about sort of like how it occurs, what sort of things we can do to try to manage that, including just sort of watching and waiting to see how things go in terms of symptomatology, getting into our medical management, and then we're briefly touching on surgery. What is the prostate? Well, basically, it's this chestnut-sized gland surrounding the urethra. You can find it here kind of directly below the bladder. Normally it's not too large, but you'll find the different hormonal influences can stimulate it to grow depending on kind of what's going on. We'll typically see that its function is mainly to secrete fluids that make up a pretty decent amount of the ejaculate volume. And you'll also find that due to its high zinc content, it actually provides some nice antibacterial secretions, kind of lending to why male patients are also sort of more resistant to UTIs as a result of this. So typically you're going to find the prostate will grow in the presence of androgens like testosterone and its more potent counterpart DHT or dihydrotestosterone. So you see that first spurt happen around puberty, and then a second growth spurt tends to occur around age 40 or so, and then will continue on as life develops and patients get older. You'll find that it has a couple of different types of tissue here, and this is important in terms of what sort of influences, what sort of neurotransmitters or hormones will influence it to cause different effects. So for instance, the epithelial or glandular tissue does produce a lot of the secretions that we mentioned before, and this can be stimulated by androgens. It can cause hypertrophy of those tissues there. Whereas there's smooth muscle associated with this as well that has a lot of alpha-1 receptors. And so we'll see that if you were to cause activation of those alpha-1 receptors with things like norepinephrine, you could cause contraction there, which can impinge upon the urethra. There's also this capsule that has some fibrous connective tissue and some small smooth muscle here, but this is going to be less clinically relevant than the other two that we were talking about already. So in terms of hormonal physiology, you're going to see that testosterone is going to be converted by this enzyme called 5-alpha reductase into DHT or dihydrotestosterone. DHT is a more potent form of an androgen than testosterone is and causes a lot of things like acne and male pattern hair growth. You'll see that it also is going to be a major influence in terms of stimulating prostate enlargement and causing a lot of symptoms of BPH. You can also see that estrogen is produced as a result of testosterone being converted via the enzyme aromatase, and that can actually also cause some effects here in terms of stromal growth as well, although less clinically significant than testosterone and DHT will be. In terms of the effects you're going to see here with BPH, there's going to be kind of two factors at play here. So there's the static factors and then the dynamic factors. As you might imagine, static factors don't really change much over time, and this is a result of prostatic enlargement. Basically, the prostate gets too large and it impinges upon the urethra, causing obstruction of urinary flow. And you can see that this is mainly due to the effects of androgens like DHT on the epithelial tissue, and then to some minor degree estrogen stimulation on the stromal tissue. Again, once that growth has occurred, it doesn't really change very quickly, and so it's more of a static, non-changing sort of thing in the short term, right? Dynamic factors are things that happen very quickly. This can lead to more episodic sort of cases of impingement on the urethra, and this is going to be mainly a result of activation of the alpha receptors on that stromal tissue, also on the urethra, the bladder neck, etc. And this can be brought about by things like stress or pain can cause closure of those smooth or constriction of that smooth muscle, leading to those symptoms of BPH. And basically, you can find that patients may be dealing more with issues from static or dynamic factors, or it could be a combination of the two. Typically, you'll find that if patients are having symptoms of obstruction of urinary flow and they have a normal-sized prostate, this is more going to be an issue of dynamic factors. Whereas if you were to have, say, an enlarged prostate, this may be a result of more of the static factors, plus or minus maybe some dynamic factors, depending on kind of how they describe their symptoms. And you're going to see that more severe voiding symptoms tend to be related to that increasing prostate size, especially as male patients are getting older. You can also find that medications can help to kind of stimulate the symptoms of BPH. So, for instance, if we're giving exogenous testosterone, that then can be converted into DHT via a 5-alpha reductase. We can find that things that activate alpha-1 receptors like adrenergic agonists like pseudoephedrine or phenylephrine can do this, so even over-the-counter congestion products can do this. And then we'll see that anticholinergics tend to cause more urinary retention, which may exacerbate the issues seen with BPH. So not only can you have an enlarged prostate closing around the urethra, but then you can also have the bladder that is more likely to hold on to more urine and cause that retention due to detrusor muscle relaxation. And that can be with antihistamines, TCAs, a lot of different medications that possess anticholinergic properties can do this. So you can see that the symptoms tend to be obstructive, and so this is basically where you have bladder outlet obstruction occurring, which can impair the urinary flow rate. You may find that emptying the bladder is a slower process and may be incomplete, and that can lead to urinary hesitancy over time, and then also kind of chronic bladder overdistension. And we can see this also leads to some other issues as well. And so you get these irritative symptoms that happen kind of later on down the road, and basically this is due to that long-standing bladder neck obstruction. Overall, over time, due to the bladder not being fully emptied, you're going to see hypertrophy at the bladder muscle, and then it becomes pretty hypersensitive. It's going to be stimulated at smaller volumes to cause urinary, the need to urinate, right? So it basically becomes less effective at storing urine because it can't really relax as well as it used to because it's so hypertrophied, right? So it's kind of like for a CHF patient who's having a stiff ventricle, how it can't really pump very well. Same thing can happen to the bladder essentially due to this chronic, long-standing outlet obstruction. What that means is that very small volumes of urine can lead to a voiding response, meaning they can have urinary frequency, you can see incontinence as a result of this, nocturia, a lot of issues. And so ideally, we'd like to prevent this from occurring as best as we can. So symptoms may not always be progressive. You may find some patients, even with an enlarged prostate, really don't have many symptoms, but ideally we'd like to prevent them from developing these lower urinary tract symptoms where you see a lot of those irritative symptoms that can happen over the long term. And again, you can see as a result of that complications like neurogenic bladder and UTIs that can develop. So other things you can see, which are maybe rare but can certainly occur, include things like acute renal failure as a result of urinary retention. You can see things like hematuria. You can see bladder stones, all kinds of things here we'd like to avoid if at all possible. And so depending on symptomatology, we may initiate medications to help out with that. So in terms of treatment, you can see that if just for mild symptoms, watchful waiting is totally appropriate for most patients here. With more moderate symptoms, we're going to look at our different medications that may be useful here. And a lot of it is going to look at what are the comorbid conditions, what sort of size of prostate does the patient possess, and then kind of what other issues they have going on. We'll look at those individually. And then for more severe symptoms, especially if they're developing complications, this is where we may go into looking at surgical options or even a prostatectomy and just getting rid of the whole prostate entirely. So our desired outcomes would be to reduce lower urinary tract symptoms, try to prevent any of these complications that we saw previously, and hopefully prevent the need for surgical intervention there. And ideally, we want our treatment to be well tolerated, meaning not a ton of side effects, and then also be pretty cost effective if at all possible. So in terms of pharmacologic therapy, we're going to see we have things that can help relax the prostatic smooth muscle. So these are going to help to reduce those dynamic factors, including things like alpha-1 adrenergic antagonists. You're going to see these have no effect on prostate size. Okay, these are only going to deal with that constriction of that smooth muscle. You can have things that help to reduce testosterone stimulatory effects, and so these are mainly going to be our 5-alpha reductase inhibitors, and these will shrink down the prostate. These are going to be good for helping to reduce those static factors. And then for more long-standing effects or complications, this is where we can try to get into things that help the bladder to store urine more effectively, and so these are going to be things that help to relax that detrusor muscle, including our antimuscarinics. So how we determine our agent to use is going to be on a case-by-case basis, and recall that these medications are only going to be useful as long as they're being taken. So if you have a medication to help shrink down the prostate and everything is going well, they stop taking that medication, all that DHT is going to come back and the prostate is going to grow just as big as it was previously. So they need to be consistent in terms of taking this to get those effects. Typically for a lot of patients, we're going to use alpha-1 antagonists as our first-line therapy, mainly because they work very quickly, because they're working on those dynamic factors. They tend to have fewer side effects overall. We're going to see that 5-alpha reductase inhibitors are better for patients with cardiovascular histories or if they have really significantly enlarged prostates. And in some cases, combination therapy may be useful. So we also can find that patients with erectile dysfunction may benefit from the use of PDE inhibitors like we talked about previously. Basically, these can work as smooth muscle relaxants that can help relax the urethral smooth muscle to allow for better flow. And then for mostly irritative symptoms, so again, kind of the later complications, this is where we're going to use our anticholinergics. Okay. Be aware though that you don't want to have this being used in patients with high post-void residual, because those anticholinergics will cause you to hold on to more urine, and that may lead to even further overdistension. So the alpha-1 adrenergic antagonists come basically in 3 generations. We don't use the first generation much anymore, mainly due to the fact that, not only would it work on the prostate, but also works on the vascular smooth muscle, leading to hypotension and compensatory tachycardia and arrhythmias. We don't use those much anymore. We nowadays will use things like 2nd generation and 3rd generation. The benefit of the 3rd generation is they tend to be more uroselective, meaning they're going to work mainly on this alpha-1A adrenergic receptor, which is primarily found on the urethra and the prostate. In terms of efficacy, both can be equally efficacious, but you're going to find the 3rd generation tends to have fewer side effects due to its increase in selectivity. But again, these have no effect on prostate size. These just help out with that smooth muscle constriction or relaxation. So we've talked about 2nd generation agents before when we talked about our hypertension meds. So things like prazosin, terazosin, doxazosin, and then alfuzosin is probably the new one here. And so be aware that because these cause smooth muscle relaxation on the vasculature and also in the prostate, you can see things like orthostatic hypotension, dizziness, compensatory tachycardia, and first dose syncope. So frequently, if you can give these at nighttime when patients are more likely to be in bed and not standing up and getting back down, this can be helpful, right? Obviously not great if your patients are up frequently to go to the bathroom, but this can be a way to kind of mitigate some of those daytime side effects. Start low and go up slow. This is not something you have to fix right away for the most part, and so if you can try to slowly titrate up on their dose, see how they tolerate it, especially if they have like a significant cardiovascular history, be cautious, right? You're also going to find that these have pretty synergistic effects with other antihypertensives, so if they're on a bunch of other stuff for their blood pressure, be cautious, because this can be synergistic and cause one, it could get them in range, which may be nice, or it could potentially bottom them out, so you do want to be cautious with that. We like longer acting agents because they don't have as big of a peak dose effect, meaning you're not going to find such a big drop in that blood pressure. And so things like doxazosin and alfuzosin are preferable because of that. We find alfuzosin tends to have the lowest incident of systemic side effects, so that may be a nice option there. It doesn't require a lot of dose titration, but it is a newer agent, tends to be more expensive than some of the old ones like doxazosin and prazosin. So in terms of our 3rd generation agents, these are very selective for the alpha-1A receptor, meaning they're working mostly in the prostate without having a lot of systemic side effects. That's one of the big benefits here. Tamsulosin is probably the most common one you're going to run into. I see this being used frequently as well for patients who have kidney stones, to help them pass those, mainly because it helps with relaxation of the urethra and a lot of those urologic smooth muscle to help that pass that a little bit easier. So you may see those used in both cases, but tamsulosin is a good one. Silodosin is not used much anymore, mainly due to the issues with like drug interactions and organ impairment issues. You have to deal with that. Tamsulosin really avoids most of that. Be cautious though, because the patients do have a sulfa allergy that may cross-react, and you do want to be watchful for that. For the most part, almost no hypotension is seen here, but you may have some issues in terms of like sexual dysfunction, like anejaculation. May see things like nasal congestion, but for the most part, pretty well tolerated. We mentioned that phosphodiesterase inhibitors can also be useful here, especially used in conjunction with alpha-1 blockers. Be cautious though, because they can cause synergistic drops in blood pressure. But the most successful combination, if you were to use these two here, would be something like tadalafil, which we know has a good long half-life, and then tamsulosin, which again we mentioned was pretty selective for the prostate. These two together would have the least likelihood of having systemic side effects, versus if I was using something like prazosin and say something like sildenafil together, you'd be more likely to see those big drops in blood pressure and risk for falls and syncope. So getting into the 5-alpha reductase inhibitors, these are going to be things that do help out with prostate size because they specifically work to block reduction of or change from testosterone to DHT. So less overall androgenic effect is going to cause reductions in prostate size. And so you have two here like finasteride and then dutasteride. You're going to find that while they are relatively selective for the prostate, they will cause overall serum drops in DHT, which means this will be the main cause for a lot of the side effects we're going to see here. This is better for patients with large prostates, or maybe if they're not good candidates for the alpha antagonists like we saw previously. So if they have a history of MI, that they are at risk for hypotension, those might not be good agents. These drugs here, the 5-alpha reductase inhibitors, may be a better option. So these can be used in combination with alpha-1 antagonists as well if you need some additional benefits. So that can be one thing you can do. And they should see a pretty decent drop in prostate size by about 25% or so. And even there are some evidence to show that it could reduce risk of prostate cancer over time, which makes sense because if you have less DHT stimulating prostate growth, then you shouldn't have as much risk for developing those cancerous cells. The downsides of using these are going to include things like slower onset of action versus the alpha-1 antagonists, which makes sense because these are blocking the effects of hormones, and we know they're relatively slow in terms of their onset. You are more likely to see sexual side effects due to things like decreased libido and ejaculation because it's decreasing prostate function in terms of secretions, and so maybe recommended as second line for sexually active males. So you're going to find that they can be used for the long term, but if you do stop taking them, the prostate size will go back down to baseline. We mentioned the sexual dysfunction. Not only is it related to the overall decrease in DHT, but there's also some thought that it may influence the nitric oxide pathway, which may make things like your phosphodiesterase inhibitors more necessary to kind of help contribute to that process there, and decrease libido, due to those overall decreased androgenic activity. Things you may see in terms of common adverse effects can also include some feminizing things like gynecomastia in male patients, and then these are going to be pregnancy category X, mainly because if a pregnant patient or someone who might become pregnant is handling these, you never really want to mess with hormone function in a developing fetus, and so there's kind of pretty big effects in terms of causing birth defects and whatnot. So, for instance, if we're using this in the hospital pharmacy, we make sure that any female patients are definitely handling these with gloves because we don't want them to have any accidental exposure should they potentially be pregnant. So, as I mentioned, you can use phosphodiesterase inhibitors in conjunction with these BPH meds here. As I mentioned, using a longer-acting one like tadalafil has the most evidence behind it, mainly because you're going to get less peak dose effects there. And then themselves can work to help relax that smooth muscle by, again, preventing the breakdown of cyclic GMP and causing less calcium influx into that smooth muscle. Now, anticholinergic effects may also be helpful here for those irritative symptoms that happen over the long term that kind of mimic the effects of overactive bladder. And we're going to look at those in more detail in a second when we get to urinary incontinence. Overall, though, you want to make sure you're starting with low doses and titrating up to see how they respond to it. You'll see that anticholinergics are not great in elderly patients anyway because it tends to have a negative effect on their mental status. It may look like worsened dementia and things like that, but it could just be related to these anticholinergic effects here. We'll talk about these more in just a few moments. In terms of surgical intervention, the gold standard would be a prostatectomy. However, this can lead to issues of incontinence later on and some other complications. So, again, ideally our medications are used to prevent this from occurring, but this may be the end-all kind of therapy for these patients. So, moving then into our urinary incontinence, we're going to see here that basically this is involuntary leakage of urine associated perhaps with some urgency, and you may see some increase in frequency in the need to micturate, right? Not only that, but can affect things like self-esteem, can worsen depression, etc. So, ideally, we like to be able to manage this as best we can to help prevent some of these kind of knock-on effects. So essentially what we're going to find here is that with the lower urinary tract kind of made up here from the bladder down through the urethra, including the sphincters here, that's made up of this urothelium, right? And so we're going to find some hormonal effects that can stimulate the urothelium. That'll be important in just a moment. But the neurophysiology in terms of that, you're going to see that acetylcholine is going to be one of the primary neurotransmitters we're focused on, mainly because this is going to have effects on either constricting or relaxing the bladder, right? Especially the detrusor muscle and the bladder tissue itself. You don't have to memorize specifically if it's M2 or M3, but you do want to know that acetylcholine, when activating these receptors, will cause detrusor muscle contraction. It causes smooth muscle contraction here that should stimulate urination. So you can already see here by using something like an anticholinergic that's going to help to prevent that. So with the urethral sphincter, you're going to find that you have to maintain adequate closure pressure here. And so we have two main sphincters that we're going to be dealing with, including the proximal sphincter, which is going to be mostly under involuntary control, and then the distal sphincter, which is under mostly voluntary control by us, but may be overridden potentially, especially if you have issues in terms of, say, bladder overdistension and whatnot. The bladder itself should be able to accommodate increasing volume by relaxing, and this helps to prevent increases in pressure, because when you do have increases in pressure, that's typically what stimulates you to urinate. And so this compliance is really important. If you lack that compliance, or say if the bladder hypertrophies, like we talked about before, this is where you can have a lot of urinary frequency and things like where it just becomes oversensitive essentially. And so you're going to find that this has to be coordinated, or it has to be coordination between these two organs here that can be disrupted by things like issues in terms of from the brain to the spinal cord down to these pelvic nerves, which is a big issue in patients with, say, for instance, like spinal cord injury, for instance. So the first type of urinary incontinence we're going to talk about is going to be stress urinary incontinence, or urethral underactivity. And this is going to be typically small volumes of leakage, typically episodic in nature, that has to do with, say, brief bursts in activity. So say someone sneezes or they're exercising, they jump or something like that. This is where you can see this. And so most commonly you're going to see this, especially like in aging female patients for postmenopausal. I'll talk about reasons for that in a moment. But certainly things like pregnancy and childbirth can sometimes lead to changes in anatomy that make this more likely to occur, and then is more likely seen in men, typically caused by like surgery. So if they had, like, say, a prostatectomy or something, this may be a cause for that. And so you can see this being aggravated by certain drugs. So for instance, if you have an alpha antagonist like prazosin, for instance, relaxing those, potentially relaxing the urethra, that can lead to decreased closure forces from the sphincters. Or for instance, you have like something like an ACE inhibitor, much less so an ARB, but an ACE inhibitor can cause cough, potentially leading to some of these episodes of stress urinary incontinence. In terms of urge urinary incontinence, this is more so related to leakage seen with like urgency, or like a desire to void. This is mainly going to be due to detrusor muscle overactivity, and basically the pressure is increasing too early, and maybe you're going to see some involuntary contractions associated with this. Not necessarily the same as overactive bladder, because this is more of an urgency issue necessarily than just a frequency issue, even though there could be some frequency associated with this. This may be idiopathic in sometimes, but other reasons for this, including some neurogenic effects, can be things like bladder outlet obstruction, like we saw with BPH, or certain types of neurologic disease, for instance. This also can be worsened by diuretics and alcohol. So we know diuretics make you need to urinate anyway, and then alcohol itself can tend to be a diuretic by blocking the release of ADH. There's also overflow incontinence, which may be a result of urethral overactivity and or bladder underactivity. And so basically this is where you're having leakage due to the bladders being filled but is unable to empty itself. And so this is kind of chronic urinary retention. You'll typically see urethral hyperactivity is more related to BPH in male patients, or it could be due to some neurologic diseases, like I mentioned, with spinal cord injury or multiple sclerosis. Or if it's related to bladder underactivity, meaning it can't really squeeze well in order to empty completely, this can be a complication of things like diabetes, some of the neuropathic effects, or long-term bladder outlet obstruction, like we said with BPH. You're going to find that some medications can also cause this. So for instance, if you have TCAs or alpha agonists, which are going to be causing urethral hyperactivity, meaning they're going to be squeezing down too hard on those urethral sphincters, or related to things that decrease bladder contractility, like our anticholinergics, calcium channel blockers, antipsychotics, etc. So depending on how these patients, what their underlying pathophysiology is, will dictate sort of what kind of symptoms they're going to be presenting with. So for instance, if it's urethral underactivity, then you're going to see leakage that's seen with physical exertion. Or if it's bladder overactivity, you're going to see maybe some urinary frequency and urgency. For overflow incontinence, this is associated with a lot of like lower abdominal fullness, maybe some incomplete bladder emptying, and they can have frequency and urgency together. So what we're going to do for these patients may be dependent on kind of what's most bothersome to them and sort of what kind of symptoms they're developing. Depending on the volume and the frequency, use of absorbent pads may be just enough for them, right? But if it's more severe, that's when we're going to get into our pharmacologic therapy that may be useful to helping to do things like restore continence or reduce the number of incontinent episodes. You may also see that when patients become incontinent, this is frequently a reason for them to go into assisted living facilities and nursing homes. So if you can prevent that, that's really good for their overall mental health and mental status. And then obviously want to reduce adverse effects and have things that are not going to be bothersome from that standpoint, and then increase overall quality of life without increasing cost too much. So you're going to see the drugs typically are going to be good for patients who maybe are not controlled totally with non-pharmacologic therapy alone. Typically, though, if we're going to start medication therapy, you want to be including some of these non-pharm therapies we're going to see in just a moment here. And then the type you're going to be picking is going to be selected based off of the urinary incontinence type, or the drug selection will be based off that type there. And also consider the comorbidity. So, for instance, if they're on a TCA because of their depression and that's causing some of these issues of incontinence, then maybe switch them over to something else like an SSRI to be less likely to cause that. So in terms of non-pharm therapy, this is better for more mild to moderate symptoms and may help the patients to avoid things like surgery or medications. And so you can do things like lifestyle modifications or toileting, scheduling, pelvic floor rehabilitation. All of that can be really useful, especially in elderly patients who are having needing a lot of assistance. Caregivers need to be a part of this and making sure they're kind of maintaining and sticking with these sort of interventions. In terms of our treatment, mainly we're going to see that, especially for urge urinary incontinence, that anticholinergics are going to be first line. So anticholinergics including things like oxybutynin, tolterodine, trospium, sulfenacin, darafenazine, and then fesoterodine. Basically, these are just going to help to antagonize the muscarinic receptors and prevent those sort of premature detrusor contractions. So overall, they're going to help to enhance better bladder storage by relaxing the detrusor muscle in the bladder itself. Any of these can be considered equally effective, but we're going to be picking them based off of side effect profile, cost, and things like that. So as I mentioned, for the most part, anticholinergics tend to be first line for most of these patients here, and a lot of them can come in different formulations like transdermal preparations, long-acting forms, IR forms, and adverse reactions are going to be based off the anticholinergic mnemonic we've learned before. So things like Mad as the Hatter, meaning that in elderly patients you can see them becoming, say for instance, more altered. They can have hallucinations potentially. They'll be blind as a bat, meaning you can have visual changes. This may not be great for patients with glaucoma, for instance. They'll be red as a beet, meaning they can have some cutaneous flushing that may happen there. They'll be hot as a match, meaning hyperthermia is a possibility, and they'll be dry as a bone, which is kind of what we want here because this causes urinary retention, but may be problematic from other standpoints. So for instance, it may decrease motility of the GI tract, meaning constipation may be worsened, or it can cause pretty significant dry mouth, for instance. So these are things you want to keep in mind in terms of their adverse reactions. Not only that, but other contraindications would include patients who already have issues with urinary retention. I mentioned the glaucoma and the decreased GI motility, but also myasthenia gravis would also be another really important contraindication since this would worsen that disease state. As I mentioned, the mental status changes in elderly can be really important, especially if it can lead to things like falls potentially. So as I mentioned, these are going to be first line. We typically like to use extended release preparations, mainly because this helps to limit a lot of the systemic side effects, or maybe helping to deal with sort of the intensity of the side effects related to high blood levels that can be achieved with immediate release products. And so especially like dry mouth and things like that, you really want to help to mitigate that as best you can. Not only that, but consider with elderly patients, you may find that can worsen things like they have poor dentition. They can see poor nutrition intake as a result of this, or you can see oral infections and things like that. So be watchful for that. In terms of different agents we have here, just highlight a few of them. For instance, like oxybutynin, be cautious with this one because it does have a risk for orthostatic hypotension due to a little bit of alpha blockade that it has, meaning it could be exacerbated by other medications that do the same thing. And anytime you have these XL formulations, you always want to make sure you look up to see if these can be crushed or chewed. Most of them cannot. If you do that, it's going to cause the formulation to break, meaning you're going to have all that drug released at one time. Tolterodine, you do want to be cautious of patients with organ impairment, and it is also going to be a substrate for CYP3A4, so you may need to reduce the dose if they're on an inhibitor. For trospium, this one's nice because it helps to limit some of the CNS effects, because it's actually a quaternary ammonium, meaning it's a nitrogen with 4 bonds to it, giving it a permanent positive charge, meaning it doesn't cross the blood-brain barrier very easily. Also, because of that, though, it also has pretty poor bioavailability, say less than 10%. So you do want to make sure they're taking on an empty stomach to help get as much drug absorbed as you can. And also watch this in patients with renal dysfunction because it may not clear it as well. Alternatives you could use include things like botulinum toxin A, for instance. We know this is derived from Clostridium botulinum, and it's a very potent neurotoxin, which we can see being used for aesthetic purposes, but also for things like migraine prophylaxis, which we've talked about previously, and will paralyze smooth and striated muscle. And so you can do this on an outpatient surgical basis, where these can be injected into the detrusor muscle directly and can help to relax that smooth muscle by basically paralyzing it. This will last for several months, about 4 to 8 months or so, but be cautious because you can see some side effects. One, this is going to be more expensive to do, but also you can see issues in terms of things like UTIs. Urinary retention is pretty common, so good as a backup agent if you see that the anticholinergics may not be appropriate. So for urethral underactivity, things we can do to help out with this are going to be things that help increase urethral closure. You see this a lot in postmenopausal women due to decreased estrogen effects, and so by giving them estrogens, this helps to kind of proliferate that urethral epithelium and helps with local circulation. Not only that, but also increases the number of those alpha receptors that are available to help out with that closure pressure as well. And so you may see things like transdermal products being used, conjugated estrogens, or vaginal creams. We'll talk more about these when we get into them in the OB-GYN section coming up. But be aware that progestins will actually have an antagonistic effect. So especially if they've had, say, like a history of hysterectomy or something like that, you may be able to use something like an estrogen product alone to help out with this. You'll find that this may not be the one thing that fixes all the problems for them, but it may be kind of a nice added on effect if patients are menopausal, they're treating symptoms of like hot flashes and whatnot. This can be an additional benefit there. And then we'll see that if it's just urinary incontinence they're being treated for, then typically transdermal products are the only ones recommended for that specifically. So other things that can help out closing the urethral pressures or help with that closing of the urethral smooth muscle, including alpha receptor agonists. These are going to be something you want to be cautious about, mainly because we've used pure alpha agonists before, things like phenylpropanolamine, but as you might imagine, that can do things like increase blood pressure and has led to stroke in the past, so that's not something you want to use necessarily, and it's actually been removed from the market. And so instead we've kind of found some backdoor methods to increase norepinephrine release to activate alpha-1 agonists or receptors, and that includes your SNRIs. So for instance, duloxetine has an indication for this in Europe that helps out with that closure pressure. More norepinephrine being released and being kept in that synapse may help with more closure of that urethral tissue. So in terms of overflow incontinence, we already talked about agents to help out with that in terms of things that will help decrease urethral closure if it's related to enlarged prostate, things like that. So you can kind of go back to that section and check that out. But yeah, that's it for the urology section. If you have any questions, please let me know, and I will talk to you soon. Thanks a lot. Bye.